First of all, good afternoon, and I would like to thank Megamind and MegaGen for giving me such an opportunity to compete today at the final round. And let me take this chance to briefly introduce myself. I'm Dr. Tarek Diwan. I'm a periodontist, implantologist, and a lecturer in the field. And today our topic will be the role of pedicled alternatives in healed sites. So the goal of implant dentistry nowadays isn't only about restoring function and aesthetics, but it's also about how to maintain both on the long term. And in order to guarantee this, we need to work on three main zones. The first is what we call the implant osseointegration zone, and then comes the supragingival restoration zone. While the zone that is completely overlooked by most of the clinicians worldwide is what we call the emergence and the peri-emergence complex tissue zone, where basically this zone is composed of 8 interrelated variables that once optimized, then it will enhance the chances of the long-term stability of both aesthetics and function. First, by providing the functional biological tight seal protection around the implant osseointegration zone to support the long-term functional stability. And then it will as well provide the pink aesthetic framework around your white aesthetic, supporting the long-term aesthetics as well. So we say that the white aesthetics are only complete when framed by optimized pink aesthetics, meaning that if you have a single missing component of your pink aesthetic framework, then eventually you will end up with some compensatory white or pink ceramics damaging your aesthetic outcomes. So out of a gigantic bone and soft tissue surgery sequence decision map, today we will be talking mainly about the cases of the healed sites, and in specific, the role of the pedicled flaps in the healed site management, where basically we classify the soft tissue into 3 main categories based on the treatment protocol to be followed. We're starting with the thick or adequate biotypes and KT with no contour deficiency, and then comes the thin biotypes or deficiencies of the labial contour, and finally the deficiencies in the keratinized tissue and combined deficiency. So whether you're planning to manipulate the tissue on the day of the placement or on the second stage surgery, we follow some specific surgical soft tissue roadmaps that will help us reach the best possible function aesthetic tissue outcomes for the long-term stability, and at the same time with the least number of surgeries and the least invasive ones. So let's start with the first category, the thick or adequate biotypes and KT with no contour deficiency. So simply in such cases, we started with no problem, not quantitative, nor even qualitative tissue problem. So simply we follow the map of contour creation, where basically I need to create back an emergence profile following the EBC contour concept of Meda et al. And as well, that will help me proximally support the new papillae and the creation back of the new papillae, while on the labial side, it will help me as well recontour and support the tissue on the labial side as well. And this can be achieved simply with the help of a crestal incision, whether papillary sparing incisions or even envelope flaps. And the main advantage of such tissue, that whenever you're trying to do the tissue conditioning around the implant, you will never exceed the tissue threshold, and this will always end up with the optimized aesthetic framework, resulting in the perfect aesthetics. So this can be done on the first stage or even on the second stage implant surgery, and simply starting from single implant placements up to full arch rehabilitations using customized healing abutments or even provisional crowns or bridges. Eventually you will end up with the optimized aesthetic framework ready to receive your final aesthetic outcomes, looking really magnificent. So let's jump to the next category, which is the thin biotypes or deficiencies in the labial contour. And in such category, eventually you started here with a quantitative tissue deficiency. So if you're trying to do exactly the same like what you have done in the previous category, eventually you will exceed the tissue threshold, and what happens then is we will end up with recession and a longer crown. So this will leave no option for yourself or the lab technician but to do or to fabricate a malformed crown to overcome the shortcoming of the pink framework. So that is why in such cases we follow what we call the map of contour creation plus compensation, where we basically need to compensate the labial soft tissue volume on the labial side, and this can be achieved with one free grafting method or 2 pedicled alternatives that can be done on the first stage surgery or even on the second stage surgery. So let's start with the very famous free tissue grafting method. It's simply, it is a CTG from a donor site, where basically I can harvest the CTG, open the flap, place my implant, and augment on the labial side with the soft tissue grafting, position the graft, ending up with a good contour compensation. While basically, why to do so if I have local tissue available, and I can utilize the local tissue available by doing a simple roll flap where I can utilize the tissue on the crest of the ridge, the tissue on the crest of the ridge, just roll it under the labial flap, or to do a modified roll flap in cases that I lack crestal tissue by rolling slightly towards the palate and rolling that tissue into the labial to compensate the lost volume. So let's start with one example of the roll flap. And simply, like as you can see in such a case where I have a minor contour deficiency, we follow some specific incision maps to spare the papilla, to de-epithelialize the crestal tissue, roll that tissue, reflect that tissue first, and then roll it under the labial flap, supporting it with a healing abutment or a customized healing abutment. And eventually, just 12 weeks of healing, you ended up with a good compensation of the tissue, ready for your final scans and delivering your final prosthetics. That is how the patient looked on the day of the delivery, and this is how the tissue have matured so far in 3 years follow-up. Then, as well, we can do exactly the same, but on the second stage surgery, where basically, as you can see here, in that case, we started with some bone compromise. So eventually, we started with placing our implants and doing some simultaneous GBR around the implants. And on the second stage surgery, upon evaluation of the tissue, we figured out that still we can utilize the tissue on the crest of the ridge. So from there, we did exactly the same. We spared the papilla, we de-epithelialized all the crestal tissue, and from there, we reflected all that tissue on the crest of the ridge, rolling it under the labial flap, and from there we customize healing abutment to help us secure the shape of the contour of the tissue. And 6 weeks of healing, the tissue is perfectly compensated. From there, we can start with our prosthetic phase and end up with delivering our final prosthetics with good pink framework around the white aesthetics. So what if in cases that I really lack the volume of the tissue on the crest of the ridge, I can also slide more palatal to try to utilize the tissue on, to do a modified roll flap. So simply again, we can follow them specific incision designs, sparing the papilla, and here we do a mid-crestal split thickness incision, and sparing incisions as well. So I can follow this with a palatal subepithelial dissection, and from there I rotate that pedicle, rotate it under the labial flap, place my implant, and customize a healing abutment on the day of the placement, securing the flap back in place, so ending up in a 12 weeks time with a perfect compensation of the tissue on the labial side that is ready for the final prosthetics to be placed in place, looking really nice with a good pink framework. That was before, that's after, and that is a 5 years follow-up, showing you the stability of the tissue so far. Jumping to the next, which is the cases of deficiencies in the keratinized tissue and combined deficiencies. So here now we are dealing with a more serious problem where we have a quantitative and qualitative tissue deficiencies. So if you're trying to do exactly the same like what you have done in the initial category, eventually you will exceed the tissue threshold, and this will not only result in recession, but also in implant exposure, and that is really dangerous. So that's why in such cases, we follow the map of contour creation, compensation, and correction to be able to compensate the lost volume and as well correct the tissue on the labial, keratinized tissue on the labial side, and this can be achieved with 3 pedicled techniques, or three free grafting methods, or 3 pedicled alternatives that can be done as well on the first stage or even on the second stage surgery. So let's start with the first 2 techniques to increase only the zone of the keratinized tissue. So simply, the very famous technique, free grafting technique that we do to increase the zone of the keratinized tissue is mainly the free gingival graft, where we start with doing some vestibuloplasty, and then we harvest the graft, we position or we manipulate the tissue according to the extent of the defect, and following this, we stabilize it in the recipient side, positioning it, increasing the zone of the keratinized tissue. But why to do this if I have already some local tissue available at the site, where mainly I can do an apically displaced flap? So if I have some keratinized tissue on the crest of the ridge, with the help of the incision maps and some of the vertical incisions, I can mobilize the tissue in a more apical position, and finally you can end up having a good volume of tissue, good width of the keratinized tissue around the implants. But the main disadvantage in such technique that always we end up losing the vertical height of the papilla in between the implants. And in order to overcome this, that's what we have discussed earlier in our continental round presentation, is how we can manipulate the tissue by taking some additional incisions to help me recreate back the papillae in between the implants, ending up with an ideal framework of the pink around the white. So jumping to the next, whenever I need to increase both, not only the keratinized tissue, but also the volume of the tissue. And in such cases, mainly, we go back here to the free grafting tissue, the option, which is simply the CTG. And the CTG here in such situation, it can be like a regular CTG. Now it needs to be a chunky, thick CTG from the tuberosity, or sometimes I can take a lateral palate CTG, split it in half, and do a double layer CTG on top of, around the implant, so I end up with good volume and good keratinization of the tissue over by time, in case if I don't have a high muscle attachment. While actually, the other option that I can do, if I have local tissue or I'm doing in the maxilla, I can utilize what we call the apically displaced modified roll flap, where simply I do exactly like what we have done in the modified roll flap, but I shift the incision more palatally, so once I reflect that tissue, it will give me a pedicled tissue for volume and as well keratinization as well, the one on the crest of the ridge. I can take them both and move all this complex with the help of vertical incision in a more apical position. So simply in such a case where implant retained overdenture was attempt, and actually you know very well the aggressive nature of the implant retained overdenture on the soft tissue surrounding the implants. In such cases, we followed some incision maps and we did exactly the same palatal subepithelial dissection, reflecting the palatal tissue, combining the palatal tissue along with the crestal tissue, and then with the help of vertical incisions, I mobilized all this tissue on the labial side of the implants. And as well, the same was done as well on the other side, pushing the tissue thickness and volume and keratinization on the labial side. This is how the patient left the clinic, and that is how the patient looked like in 5 weeks with a good volume compared to the initial situation. You can now value how the volume and the keratinization so far was really nice, securing our implants with locator abutments and securing our implants with good volume as well under the overdenture. So this is as well a 1-year follow-up showing you the stability of the tissue so far. So jumping to the next is whenever I'm having a vertical tissue height problem. And in such cases, we always choose the free option, which is an onlay CTG. And the onlay CTG here is just simply, we harvest that CTG, we place it and stabilize it on top of the ridge, gaining the volume of the tissue, and that's it. While actually, I can utilize as well, if I'm doing that in the maxilla and I have local tissue available, I can do the VIP CTG, where basically the CTG can give me, I can rotate a palatal pedicle that will give me a vertical height on the vertically, and as well some horizontal height as well, horizontal thickness as well. So in such a case where basically implant placement, immediate placements weren't really indicated, we had no option but to extract the implant and go for a ridge augmentation procedure. And after the healing, now it's time to place the implant and evaluate the tissue. Unfortunately, as you can see, we saw that we have a lack of keratinized tissue, we have a contour defect, and most importantly, we have a vertical tissue defect. So from there, we just opened the flap, we placed our implants, and we went to the palate, and we harvested 2 VIP CTGs from both sides to compensate the vertical volume as well as the horizontal volume around both implants. And you can see the instant gain of height following the surgery. Then we left the tissue mature for another 3 weeks, and then we fabricated some provisionals, and we waited for another 3 months for the tissue to keratinize and mature properly. Then we opened on top of the implants with some roll flaps on top of both, sparing the papilla as well. From there, we finalized and delivered our final prosthetics on top of the implants, securing them with a good volume of tissue. And this picture is showing you a 1-year follow-up as well of the after delivery of the prosthetics. And that is why we say that the white aesthetics are only complete when framed by optimized pink aesthetics. So finally, my take-home message is, first of all, whenever I have the option of free versus pedicled grafting, I would definitely choose the pedicled, because usually they are less invasive, they are vascularized with a very high success rate, and most importantly, they are widely accepted by the patients. While in case that I lack any tissue available at the site, then I have no option but to shift back to the free tissue. So my second message, that every patient we treat as well is like a picture that is full of details. And all these pictures you're seeing at the moment aren't real pictures. They are just few of my pencil drawings. And that is why we say that the white aesthetics are only complete when framed by optimized pink aesthetics. Then it was never about the details. It was always about the details within the details. Thank you so much, and hope you enjoyed the lecture.